Good afternoon, everyone, and thank you very much for logging to our webinar today. This is the Regional Surgical Advisory Network of the Royal College of Surgeons of Edinburgh, and we're extremely privileged to have Mr. Barnabas Green, one of my consultant vascular surgeon colleague from James Cook University Hospital here this afternoon. He's a very experienced speaker, and those of you who've been following the series would have listened to his lectures on several different topics. And today the topic is going to be on carotid endarterectomy, and this is a very important topic, also something that's not very well taught in medical school. And we're going to get a very educational as well as entertaining talk from Mr. Green today. Now, during the course of the talk, hopefully this will be around 20-25 minutes. There's the Q&A option that you can use to ask questions as Mr. Green is doing his talk. And also there'll be some questions right at the end of the session that we can go into and just to enlighten you on the final points of the talk. So without much ado, I'm going to pass the mic on to Mr. Green. Thanks, Barney.
Thanks, Peng, very much for that kind introduction. As always, I think you over-egg a little bit about who I am and what I can deliver. On the entertainment front, at least anyway, I don't have any jokes for you about carotid endarterectomy. If I had one, I would share it with you. The title, if you look on the webpage, actually says Management of Carotid Disease, but that is a huge, huge subject, something that you simply cannot go into any detail in 20 minutes. So I thought rather than try and sketch over key parts of carotid disease, let's hone in on one aspect of that management process, which is carotid endarterectomy, talk about that in a little bit more detail, and hopefully provide you with some assurance that your role on the ward, managing these patients post-operatively, is relatively straightforward. So that's really the take-home message today, what we would want you to be able to understand on the ward in managing patients who've had carotid endarterectomy. So just as a way of an outline of where we're going to go, we're going to touch on the indications for carotid endarterectomy. And for this talk, and I would stress that really it is only about this talk, I'm going to concentrate just on symptomatic carotid disease. So we're not going to include those patients who are found to have a stenosis of the carotid artery as an incidental finding. We're not going to talk about management of carotid artery stenosis in concurrence with other surgeries, for example, coronary artery bypass grafting, and so on and so forth. All of that discussion really does fall under a much more in-depth and often postgraduate set of studies. So we're going to leave that out, and we're just going to focus on those patients who end up going for surgery who've had symptomatic disease. Within the talk, I will mention a number of trials, not that many, from which we have got the evidence on which we have based our practice. Now, every trial fundamentally has some sort of a flaw to it, an error built within it. That's how we've made trials, but we have to accept them for what they are. And the trials that we still refer to are nearly 40 years old. So you might say, is that even relevant these days? And the answer is it's as good as we've got at the moment. And yes, medicine has changed over that, the last 10 or 20 years. So we might not be quite comparing apples with apples. But like I say, it's as good as we've got. It's formed the bedrock of everything that we do thus far in respect to carotid endarterectomy. So that's there. Now, there are many, many, many trials in the carotid world. So we would take 2 hours trying to even name them all. I'm only going to mention 2 or 3. And if you want to know more detail, you must go and find the textbooks and dig into those and look at the evidence yourself. And the vascular and endovascular companion series has a great chapter on it. And it's, that's where I would encourage you to go and read that if you felt so inclined. We're going to talk a little bit about the surgery. We're not going to talk about carotid artery stenting, but we're going to talk about the surgery, not because you need to know the surgical technique necessarily, but because within the surgery there are risks, and it's those risks that would come to you on the ward post-operatively that I would like you to know about. And then finally, we're going to look at some key points of post-operative management. The first thing to say is, what is an endarterectomy? Now, a lot of people miscall it endartectomy. It's actually arterectomy. Endo coming from the word internal, arter, as in of the artery, and then ectomy meaning to cut. So quite literally, we are cutting out the inner layer of the artery in this procedure. Now, this is not specific just to the carotid artery. We can endarterectomize any artery. Now, some arteries don't do well to end arterectomy, and other arteries respond quite well. So the femoral artery, for example, the aorta and the carotid are quite good arteries to go and end arterectomize. What are the layers of the artery? I know you all remember this, but there's essentially 3 layers. That's the adventitia, the media, and the infima. As we live a bit, we start to lay down plaque, atherosclerotic plaque, within that interface between, well, it's really within the media, and it starts to push out and destroy the intima and develop in that area. And that's what reduces the cross-sectional area of your artery, causing a stenosis. I'm quite keen to make a differentiation here between the word stenosis and occlusion. An occlusion is complete. There is no flow through it, okay? And if I don't mention it later, and if it doesn't come up in questioning later, if somebody occludes their internal carotid artery and gets away with it, in other words, does not have a fatal stroke, they do not need carotid endarterectomy, because that's actually a very safe place to be. The reason for that is no flow goes through that artery, therefore they cannot embolize again through that artery. But stenosis and occlusion in your parlance need to be very distinct. Occlusion is a blockage, stenosis is only a narrowing. So make sure that you pay attention to that as you go forwards. And you'll often see reports coming back saying there's a 50% occlusion. Well, you get the point. So what about the plaque development? Again, going back to the first or second year of pathophysiology, I'm sure you'll remember about foam cells and fatty streaks and so on and so forth. But if you can actually tune into this with your eyesight, it is quite small writing, I'm afraid, you can start to see that we develop disease within our arteries at a microscopic level or a histological level, even from the very first 10 to 20 years of life. That's more or less where most of us are now. I include myself in that young group. We are actually in the process, if we're not careful, of laying down disease patterns within our arteries that could come back to bite us later. If you are a smoker, if you have diabetes, if you engage in a heady lifestyle of eating many, many cream cakes, I would encourage you now, make sure you start to look after yourself. Because if you slide down that scale and you become a complicated lesion that could sit there silently for most of the time, you're not that far away from plaque rupture. And if that's a carotid artery, that could be a stroke, and that could be a very dangerous place to be. One last thing to say really about carotid endarterectomy, if you actually want to get involved in this type of surgery, is this is the closest thing you will ever get to bomb disposal in the surgical world. If you look at that bottom picture there, which says complicated lesion, and you can see the thrombus having erupted through that plaque, we are taking a patient to theatre, maybe within days of their cerebral event, and we are trying to get to that before it causes any more trouble. Too much wobbling around, too much shaking and vibrating with your instruments could shower off an embolus, and you will give that person exactly what you're trying to prevent to do. Cut the red wire, cut the green wire. That's a scary thing in bomb disposal, I'm guessing, never having done it. But here we're talking about really very much gentle touch of the skin of the artery to not shower this off and accidentally set off the bomb. So why do we perform carotid endarterectomy in the management of carotid arterial disease? I want to try and confuse you a little bit. When you were at school and you did mathematics, you got an equation that looked a bit like this. 8 plus 3 equals x. And then it says, what does x equal? And depending on how many fingers you've got, you can count that up and you can solve x. But mathematics at that level was always question, solve the answer. Well, in medicine, we invariably end up with the answer. A patient presents with a set of symptoms or presents with a condition, and then we have to work backwards and try and say, well, what plus what gave you your stroke? Over the years of examination, of investigation, it becomes apparent that the carotid artery is responsible or could be responsible for having given an embolic event or an ischemic event to somebody's brain. So our equation is stroke equals A plus B, where A equals an embolic event, for argument's sake. What does B equal? So if B equals a significant ipsilateral, that means the same side, internal carotid artery stenosis, then there is a future risk of stroke. So we can't be sure that that stenosis caused the stroke, but in the context of you've had a stroke and you've got a narrowing, we reckon that's probably the culprit, so we will offer you that surgery. Now, on the right-hand side of the screen is something called the carotid stenosis tool. This is actually a stroke risk calculator or prediction calculator, and it's developed by very clever people looking at an awful lot of research and data over the years. And we can plug somebody's numbers into this and come up with a risk, and we'll look at that in just a minute. But at the end of the day, that risk is that estimate of what that patient might have in the future if they don't have their surgery. They will have a stroke risk, and what carotid endarterectomy wants to do, not eliminate risk, not to undo what's been done already in terms of the stroke effect that they've had, but simply to reduce their future risk of stroke from that artery by about a half. Now remember, there are 3 other arteries that go to the brain. We can't prevent stroke from any of those 3 by operating on that one culprit lesion, but that's what we're trying to do with a carotid endarterectomy. So what does that risk calculator actually look in real life? Now, where we live in the northeast of England, we have quite a high level of deprivation and therefore with it arterial disease. So if we were to take the average 60-year-old male who 7 days ago had a single cerebral transient ischemic event, who has got an ultrasound scan that says carotid artery stenosis, 70%, and they got diabetes, they've had a heart attack in the past, they've got some claudication when they walk, and they are treated for their hypertension, then we'll put that data in, and the calculator will say, listen, if that plaque is irregular or ulcerated, like we saw in one of those first slides, their 1-year risk of having another stroke is in excess of 20%. And if we fast forward 5 years, 1 in 2 of these people will have had a stroke if you don't do anything. That's exceptionally high. We accept 20% at 5 years as an indication to intervene. So more than 50% at 5 years, that sounds pretty bad indeed. And of course, the next time they might not be so lucky. It might not be a TIA. It might actually be a fatal stroke. So that's really the rationale as to why we do carotid endarterectomy as part of the management of carotid disease. I thought we'd just mention very briefly how we measure that stenosis and the history to why we've got to where we've got. Because you may have heard things, oh, less than 30%, 30 to 70%, greater than 70%, or when do we treat? So what I thought is spend 30 seconds just talking through the history of how we've identified stenosis and then tell you what we do these days. There were 2 big trials, the North American trial and the European trial. And what these guys wanted to do is say, look, we need some consensus opinion on whether surgery or best medical therapy is in a patient's favor. And the way that they ascertained stenosis was to put a needle in the artery, inject some contrast, so that's needle angiography, take a picture of the carotid artery. That dotted line where you can see C, you wouldn't actually see, you'd only see contrast running up through the tube of the artery. So you're imagining where the carotid bulb would be ordinarily. And then we take some measurements so we can work out how much of a percentage stenosis there is. But they didn't agree on how to do their measurements. So NASET took A minus B over A, and the Europeans took C minus B over C. Well, the outcome of that is that although they both get a percentage, the percentages are very different. So a NASET 12% stenosis is a European's 50%, and so on and so forth. I've put a box around the pertinent one because at least they agreed on one thing: greater than 50% for North Americans and greater than 70% for Europeans. By the way, this is all and less than 99%, because remember, a completely occluded artery you don't need. But for those 2 patients, that's when for both those 2 percentages stenosis, that's when a discussion with the patient to say carotid endarterectomy could convey you a benefit in the future. Would you like it? That's what they both agreed on. Because it's confusing, we have settled for one set of measurements, and we only quote one set now, and that is the NASET quote. So if somebody did a duplex and said there is a 60% stenosis, it's NASET. If they said there's a 40% stenosis, it's NASET. And that should tell you roughly whether they do or don't qualify for surgery. Things have changed a little bit as we've advanced in our expertise, simply because a needle angiogram carried with it, just for doing the test, a 1 to 2% risk of stroke. So patients were having strokes by the test designed to have a look at the artery, and that's just not acceptable. So these days we have non-invasive modalities. An excellent vascular ultrasonographer can measure stenosis because they can measure the velocity of the blood through that stenosis. And using another calculator, that velocity equates to a particular percentage. They can also look not just with Doppler, but they can look with the B mode, so the architectural picture on an ultrasound scan, and say, oh, that looks like an irregular plaque, that looks nasty, and so on and so forth. So duplex is an excellent estimate of stenosis, but then we also want a second modality, we believe, that could be another duplex by an independent practitioner, but more often than not, it's an MR angiogram, an MRI scan. That has two benefits. Firstly, it looks for any distal disease, so not just the lesion at the bulb, but is there anything else in the carotid artery? And if you do something called a diffusion weighted imaging, a DWI, and you do that within a particular time of their ischemic event, you will see little white dots in the brain. So you can say, yes, that's definitely in the carotid territory that they had their event, and so on and so forth. CT angiogram is also used. In our particular unit amongst the surgeons, we don't favor it simply because there is often a lot of calcium within the artery, and that makes an estimation of the stenosis really quite difficult. So that's how we ended up measuring our stenosis. If you want to go and read more about those trials, because they are vast, then those are the two names, NASIT and ECST. What exactly is the significance of the stenosis, and why was it that that stenosis said we should go for surgery? Well, yet another group of people said, well, let's combine data from all of these European and North American studies, and we'll add in another one from the Veterans Affairs study. We'll combine all of the data, we'll standardize it to the NASET angiographic measurement method, and we have over 6,000 patients here. And what we want to see is, if you take less than 30%, well, you can see the boxes there on the left-hand side, when is surgery helpful and when is it not helpful? And at the end of the day, how many people do we need to treat to prevent one stroke? If your numbers needed to treat were 200 to prevent one stroke, that seems pretty crazy. But at 70 to 99% stenosis, you need only treat 6 people to prevent one stroke. And remember, that stroke could be fatal. So for every 1,000 patients that you're treating, and the maths looks a bit odd here because we don't have percentages of people, you roughly prevent 159 strokes. The other thing of saying, well, the reason why we don't operate on those with a mild degree of stenosis is that at less than 30%, you're actually causing harm from the surgery in the long term. So your the negative number there is that saying we're not preventing, we're causing stroke. So that was something that was quite interesting. So I've circled those 2 boxes because these are the guys that always end up going for surgery or being offered surgery anyway. Further data or further analysis of that data also said, well, what if we were to wait? So some people didn't get their surgery straight away. What you can see here is that the relative risk reduction, the actual relative risk reduction in stroke at 5 years is quite significant. If you operate within the first 2 weeks, you will reduce that stroke rate by nearly 20%. If you wait for more than 12 weeks, you're only reducing somebody's risk of stroke by 0.8% or thereabouts. So this tells us something about timing, and that's highly relevant to those of us who control the carotid artery pathways to make sure we try and hit the target, which we have of 14 days from symptom to surgery. So if you do end up in a specialty that doesn't actually operate on carotids, but you are in a medical specialty who is referring people in, don't delay in that referral, because symptom to surgery, 14 days, there's another drive to get that to 7, and there's yet another drive to get that within 48 hours. But we can't operate on somebody within 14 days if we only find out on day 13. And then you start to see that their benefit from their surgery in the long term starts to tail off. What about the UK? What is the burden of the disease and why are we doing most of the carotids that we're doing? NVR is the National Vascular Registry. All of us vascular surgeons are mandated to input data into that every time we do an operation. So in 2019, the report came out for the activity in 2018. And if you look at this, we can see that 78% of people had their operations because they either had a carotid territory stroke or a TIA. 14% had visual loss. That's something called amaurosis fugax. And actually, the blood supply to the eye, it's kind of the end extension of the carotid artery. So in these people who have ipsilateral visual disturbance, we treat that as almost like an eye stroke, and they would also get benefit from surgery. So 4,200 cases in 2018, that's quite a lot of cases. If you're asking the question, who should have a carotid endarterectomy, I always ask three questions. Three questions that I must satisfy in my mind before we take them for an operation. First of all, has there definitely been a carotid artery territory ischemic event? If it's a hemorrhagic event, they're not for us. If it's a vertebrobasilar territory, they're not for us. So it definitely has to be carotid artery territory event. Stroke symptoms can be very confusing. And remember, we're cross-wired. Left does right, right does left. So we don't make that decision in isolation. In actual practice, we are part of a multidisciplinary team meeting. The stroke physicians would say, we've had this patient who's had a carotid artery territory stroke. If you want to know their symptoms, this is what they had: slurring of the speech, facial droopiness, etc., etc. For the times when the symptomatology is equivocal or difficult to understand, that's really where you must take the advice of your stroke colleagues, because that's really important. So number one, has there been a carotid artery territory ischemic event? Number two, is there an appropriate ipsilateral, same-sided, internal carotid artery stenosis? Remember, less than 50% don't need surgery. Anything greater than that, they do. Now, there is one final part of the percentage that I've not touched on, and that's a near occlusion. Something that's nearly blocked doesn't get benefit from surgery either. In fact, we don't operate on them because nearly blocked is practically blocked. And if you take them a week later down the line and scan them, you'll find that that artery has finally occluded. So they are excluded from this. So it has to be 99% down to 50%. The third question really obeys the old maxim of vascular surgery. For any artery to be opened, you must first get proximal and distal control. If you can't do that, you can't isolate the artery, you open that artery, it's a bloodbath. So if the carotid stenosis is all the way up to the brain box, that's not going to happen. We can't operate on that because you can't get distal control. If the lesion is extremely high, you might be able to get below it, but again, you can't get above it. Sometimes you have to do weird things, dislocate the jaw, do a nasal intubation, divide various muscles up in the neck to get access. But if it's not surgically accessible, they can't have it, even if they fit in the right percentage stenosis. What if they've had radiotherapy to the neck? What if they've had previous surgery? What about their comorbidities? Does that make their surgery actually much more risky than their future risk of stroke? So these are the questions that you must engage in a very intelligent way with. And by the way, all of them need to be managed with best medical therapy. So blood pressure control, antiplatelet, statin therapy, etc., etc. Well, what about the risks of surgery? In order to talk you through the risks of surgery, I thought I'd show you some rather cat-handed drawing of my own. This is the carotid complex. Of course, I'm sure you'll all appreciate that the uppermost red tube is the external carotid artery because that's got a branch on it, the first one being the superior thyroid artery. So the internal carotid artery does not have branches in the neck. I say it doesn't, almost never. Occasionally we see a branch on it, exceptionally rare. At the lower margin, that purple structure is the omohyoid muscle. At the top right of the screen is the digastric muscle. And then the purple one that's slung backwards, that's the stenomastoid muscle. Then you've got the internal jugular. And in that space between the artery and the jugular, or inside the carotid sheath, is that stringy yellow structure, which is your 10th cranial nerve. So that's your vagus. And then running awkwardly across the top of the complex, nearly invariably always in the way, is the hypoglossal nerve. Now, I'm told I have an enormous hypoglossal nerve, but that's just because I do a lot of talking. I'll leave that to you to decide. So you must get adequate exposure, but in that exposure, you could damage the cranial nerves 1%. And that's usually transitory, as in it's because you pulled on it and it settles down, but it's a possibility. Bleeding from the vein, usually a little tie that comes off and they cough 3 hours later and you get a surge of blood. That's all there as well. The gray lines indicate clamps. Before you open the artery, you have to clamp it. Of course, clamping interrupts the blood supply to the brain. So if you do not have strong contralateral blood supply, then you could actually, if you leave those clamps on for too long, starve the brain of oxygen and they could have a stroke. Stroke is a risk. In this area here, we've got the carotid bulb, and in that area are various receptors that deal with your heart. So for somebody who's incredibly sensitive in the carotid sinus, they may have cardiac dysfunction. So heart attack is also a risk. Once you've got the artery controlled, you then open it and you put in a plastic tube called a shunt. Now that restores blood back to the brain, and usually we have about 6 minutes in total of clamping and declamping when the brain is ischemic, and the rest of the time it goes through that shunt. But the shunt itself gets pushed up and you cannot see where the top end of that shunt is. So you could go up there and trawl the intima off the artery, causing a flap so that you think you've done beautiful surgery downstream. The blood comes in, hits that flap, can't get to the brain, and they have a stroke. So bleeding, stroke, nerve injury, heart attack. Those are probably the 4 big things that I would quote somebody. And for you post-operatively on the ward, the 4 things to think about. Finally, we close the artery with a patch. Your choice of patch is highly dependent on your local practice, so I won't go too much into that. If we look at our data again from 2018, we can see that 2% of patients died or had a stroke within 30 days of their procedure. Now, we don't know why they died. They might have stepped out into the road accidentally, or they might have broken a hip and died of pneumonia. But the point is, it was done sufficiently close to surgery for us to get the responsibility of that death. That's national data from 2018, 4,000 cases. It's hard to say that that's inaccurate. So the risk of stroke is somewhere between 1% and 3%. Let's call it 2%. Most patients stayed a couple of days in hospital, and a number of people were readmitted. Why they were readmitted again, we don't know. Whether it was really a complication of that or not, I don't know. But this is something that we get picked up on. But like I say, I think the key risks are nerve injury, bleeding, stroke, and cardiac dysfunction. What can we do to try and reduce the risk of stroke intraoperatively? You can think, how should we best give somebody an anesthetic? General anesthetic or local anesthetic? There's a trial. It's called the GALA trial. Have a look. Shunt or not shunt? If somebody's asleep, they must have a shunt. If they're not asleep and they have local anesthetic, you might not have to shunt because they've got good contralateral supply. So the problem is, if you don't shunt 20 patients in a row, and then you have to shunt the 21st, you might be a bit shaky and you might actually cause more harm than's good putting that shunt in. So that's where the danger comes. Standard versus eversion endarterectomy. This is an eversion endarterectomy where you open the artery and yank the atheroma out. This is the standard. This is standard practice. This is still done, but not necessarily standard. Tacking down the end of the intima so it doesn't flap up and strip off. These are called distal tacking sutures. A patch repair versus direct repair where you just close the artery. I mean, imagine this. You've got a stenosed artery from atheroma. You open it, you clean out the atheroma, and then you close it directly, causing a stenosis again. It's a stroke risk, so close it with a patch, leave everything nice and open. An intraoperative Doppler check, if you listen and the flow is good, you've done your job. If the flow is bad and it sounds like it's hitting something, now's your time when they're still asleep to open it up, have a look and see why the blood flow is not working so well. And the last thing really that we can do to try and reduce the risk is high volume centers. The same people who do the same job over and over tend to get better results. So if you work in a hospital where there's a vascular unit, you will probably find yourself on the receiving end of carotid endarterectomy. Post-operatively, and these are the last 2 or 3 slides you'll be pleased to know, post-operatively, all patients must get level 2 care. Now we can do that in a post-anesthetic care unit or in a high dependency unit, whatever the local setup is. But fundamentally, there are 4 things to monitor: blood pressure and heart rate, the airway, your wound. Your airway and your wound kind of are inextricably linked because your airway would go if your wound starts to bleed. We put a drain in, and that drain is designed to catch any mild bleeding, that, take it away so it doesn't bruise up in the neck and become painful. But if it suddenly fills after a cough, don't think, well, we'll see if it stops. It usually is a problem. Conversely, drains also block. So don't take an empty drain and a big swollen neck as, well, everything's all right, because there's nothing in the drain. So be very mindful about drains. And the last thing is new neurology. There is something that I want you to go and read about. It's called hyperperfusion syndrome. And that can get you days and days after your carotid endarterectomy. And it's quite often fatal. It's not a good place to be. But uncontrolled blood pressure happens because your cerebral regulation has been used to running on a tight stenosis. Suddenly that's gone and the brain can't really cope. So that's why level two care is really important, with a direct arterial monitoring on all the nursing support for the medication that they need to keep your blood pressure and your heart rate under control. We've developed algorithms for managing the blood pressure. Every unit should have those, and they should be readily available. Eventually they come back to the ward. Quite often they go home straight from PACU, but occasionally come back to the ward. And I think for you, the main things are going to say, what could go wrong on the ward? When is it safe for them to go home? I think, as I've said before, there are three main complications: bleeding, hypertension, and new onset of neurology. If you look at this flow chart, the bottom of each one pretty much says, get some senior support. So these are big kahuna type things. If somebody is bleeding, they're in trouble, they're going to need to go back to theatre, or at least they're going to need an assessment and a senior colleague to take that responsibility. New onset neurology, if they have another stroke, that's a terrible, terrible outcome. And often there's not a lot you can do, but your senior members need to know. As for managing your high blood pressure on the ward and your bradycardia or your hypotension, we have locally agreed algorithms. Everybody should have them. You must use them. All patients should be back on their best medical therapy. Everybody needs to be normotensive on their usual medication. So you can't say, well, they're normotensive, but they're still on intravenous drugs. So that's just not good enough. Normotensive on your usual medication. And as long as you're medically and socially fit for discharge, you can go home. And our record is about come in on the day of surgery, go home the next day. So we're doing okay with that. So that's about all I want to cover. I've probably gone a little bit over time. I hope Mr. Wong's had a chance to answer some of your questions. If there are one or two questions left, we can try and answer those now.
Right, thank you very much, Barney, for the very clear, concise, comprehensive talk. And I think we've got a couple of questions. The first question is EEG monitoring helpful to prevent post-carotid endarterectomy stroke?
To be honest, I have never done it. I've never worked in a unit that's done it. The closest we've ever got to doing is transcranial Doppler intraoperatively. By that, what you do is there's a little window around the temporal bone here where you would put your transcranial Doppler, and you're listening for little clicks in the flow. Now, some people like doing it. All I find that does is it makes the surgeon incredibly stressed, because any minor movement, you hear a click and you think, gosh, am I giving this guy a stroke? And remember, we've said this is like diffusing a bomb. You've got to be as calm as you can be. So would I like to operate again on somebody under local anesthetic? Well, I think if we had to, we would. But a patient under local coughs, gags, moves, they're there for 2 hours. It's not pleasant. It makes me stressed. It makes them stressed. And that never ends as well as you'd like it. So you want people to be as relaxed as possible. So EEG management afterwards, I don't see any role for that in preventing stroke. Meticulous surgery, that's probably the key. Doing the same thing over and over and over, that's another key. And excellent perioperative medical care. For me, those are the most important in preventing a post-carotid endarterectomy stroke.
Barney, that's absolutely right. I think there is currently, as you've kindly explained, there's no current gold standard for minimizing the risk of stroke. There's transcranial Dopplers you alluded to, there's the EEG monitoring, there's the evoked potential, but as you rightly said, good surgical technique. And I think for most of us who do a shunt regularly, if you do a shunt properly, meticulously, making sure there's no blood going up to the brain, I think that's the best way. And I think with EEG monitoring, you need a skilled person, a skilled physician to be able to read it. So I think for most of us who don't do EEG regularly, I think we rely on a good sound surgical technique. And I know there's certain units in the country that will do angioscopy to look within the artery. And again, that hasn't been proven to show that.
Absolutely, yeah.
Right, there's another question. Is there an LDL target after carotid endarterectomy?
Well, I was hoping you were going to answer that one. You know, you've got to remember that we are surgeons. I am a surgeon first and foremost. So my main part of this patient's management is dealing with the architecture of the artery. The best medical management needs to be addressed. And, you know, I think it's an excellent question. How low is low? And we don't give somebody a statin to try and reduce cholesterol levels. We give somebody because we know that clopidogrel and statin are there to stabilize plaque. Stabilize plaque. if you stabilize plaque, you're less likely for that to rupture and go on and have your cardiovascular event. So I haven't got a target answer for you. You know, I leave that to the clever physicians who are involved in medical care. But Peng, if you want to answer that one, feel free.
Okay. So I think to add on to that as well, these days we're looking at non-HDL. So if HDL is good, non-HDL is bad. So that will include LDL, VLDL, VVLDL, for example. So I think if we measure it, so we're now moving towards the measurement of non-HDL. So if you take your total cholesterol minus the HDL, anything that's non-HDL is bad. So it's not just reducing the LDL, it's reducing the non-HDL. So all of that. So I think it's supposed that the level of that used to be less than 2, but I think we now have to be, with this group of patients, we just have to be slightly more aggressive in reducing their non-HDL. Barney, I think looking at the time, we'll probably cover quite a lot of topics in the short period of time that the Royal College has allocated to us. Any last minute message that we can let the participants take home?
Yeah, 2 things. CABG with carotid endarterectomy, I wouldn't advise it. You know, we've looked at this time and time again. Last time I looked, it's not good. If someone's got carotid artery stenosis and they need coronary artery bypass grafting, you need to say to them, you've got a higher risk of stroke, and leave it at that. I think the takeaway message really are those three things that you need to ask. Number 1, have they had a carotid artery territory event? Have they got a lesion that is suitably tight, i.e. the appropriate stenosis? And have they got all the hallmarks of somebody who do well with surgery? Can we get to the lesion? Can we get them safely through it and out the other side? So I think, you know, for those of you who are going to go on to do the surgery, practice, 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 and be absolutely meticulous in everything that you do. You don't want any shakes. And for those of you who are looking after these patients on the ward, they infrequently have these sorts of complications, but they can do. And your vigilance is fundamentally important, and following the algorithms for management and calling for senior help, that's really important as well.
Okay, that's great, Barney. Thank you very much for delivering such a complex topic in such a comprehensive way. So just remind all of you, the next webinar will be on next Tuesday, the 25th of August, and this will be delivered by Ms. Din from Edinburgh, and we're looking at managing large bowel cancer. So thank you very much to all the participants and the college for facilitating this webinar session. Thank you very much.
Bye-bye.
Okay. Good afternoon, everyone.